Good day, everyone. Today, our group will discuss hyperemesis gravidarum, a severe form of nausea and vomiting during pregnancy. Each of us will tackle specific parts to provide understanding of its definition, symptoms, diagnosis, and management. Let's begin with the definition.
The condition can severely affect daily activities, making it difficult to work or take care of oneself. While the exact cause is not fully understood, hormonal changes, genetics, and the intense response to pregnancy hormones are thought to play a role. Treatment generally involves rehydration, replacing lost nutrients, using medications to control nausea, and in more severe cases, hospital care with intravenous fluids or feeding. Without treatment, hyperemesis gravidarum can lead to further health issues, but most women recover after giving birth.
The clinical manifestations of hyperemesis gravidarum. So, hyperemesis gravidarum is a severe form of nausea and vomiting during pregnancy that can lead to serious complications if left untreated. So, here are the key clinical manifestations. First, we have the severe nausea and vomiting. This involves persistent and uncontrollable vomiting, especially during the first trimester. And it goes beyond typical morning sickness and can happen throughout the day. Then next, we have the weight loss. So patients may lose more than 5% of their pre-pregnancy body weight due to continuous vomiting and the inability to keep food down there. Then third, we have the dehydration. So this is the prolonged vomiting can cause dehydration, which presents as dry mouth, excessive thirst, and decreased skin elasticity or skin turgor and dark urine. Then next, we have the electrolyte imbalance. So, vomiting leads to the loss of important minerals like potassium or hypokalemia and sodium or hyponatremia, which can result in metabolic alkalosis, an imbalance in the body's acid-base levels. Next, we have the ketosis. When the body doesn't get enough food, it starts breaking down fats for energy, leading to the presence of ketones in the urine. Next, we have fatigue and weakness. Constant vomiting and poor food intake can cause general body weakness and a lack of energy due to nutrient deficiencies. Then next, we have the hypotension and tachycardia. Due to fluid loss, patients may experience low blood pressure or hypotension and a rapid heart rate or tachycardia. And then we have the psychological symptoms. The physical strain of severe vomiting can also lead to anxiety and depression, affecting the mental well-being of the patient. And then we have the reduced urine output or oliguria. It is a severe dehydration can decrease kidney function, leading to reduced urine output, a serious sign of kidney involvement. And then lastly, we have malnutrition. It is the inadequate intake of essential nutrients that can impact both the mother's health and fetal development, increasing the risk of complications during pregnancy. So, recognizing these symptoms early is crucial to prevent severe complications and ensure both maternal and fetal well-being.
In severe cases, ketones may be present in the urine, indicating a starvation state. Other manifestations include hypotension, tachycardia, decreased urine output, fatigue, dizziness, and general weakness. Patients with hyperemesis gravidarum experience persistent nausea and vomiting that extend beyond the first trimester. They suffer from significant weight loss, typically exceeding 5% of their pregnancy weight. Due to continuous vomiting, they may show signs of dehydration, such as mucous dry membrane and poor skin turgor, electrolyte imbalances, particularly low potassium and sodium levels. To confirm the diagnosis, several tests are conducted. A urinalysis is done to check for ketones, while blood tests assess electrolyte imbalances. A complete blood count may reveal hemoconcentration due to dehydration. Liver function tests may show elevated AST and ALT levels. Additionally, thyroid function tests are performed to rule out thyroid abnormalities. An ultrasound is also necessary to evaluate fetal health and exclude conditions such as multiple gestation or molar pregnancy.
This slide discusses the medical management of hyperemesis gravida or HG. HG is defined as a severe form of nausea and vomiting during pregnancy that can lead to dehydration, electrolyte imbalances, and weight loss. This slide outlines supportive care as the primary treatment approach, which includes the hospitalization for severe cases involving dehydration and electrolyte imbalances, for IV fluids to correct dehydration and electrolyte disturbance like sodium, potassium, and chloride imbalances. The nutritional support, this may involve internal like feeding tube or parenteral or intravenous nutrition, particularly in cases that don't respond to other treatments like refractory cases. Next is the dietary and lifestyle modifications. These strategies aims to improve comfort and reduce nausea triggers. The small frequent meals, eating small amounts of food more frequently helps prevent stomach from becoming overly full, which can trigger nausea. The dry, bland foods that are not overly rich, spicy, or greasy are generally better tolerated. Strong odors can also worsen nausea, so avoiding strongly scented food is recommended. Avoid triggers. Identifying and avoiding specific foods, smells, or situations trigger nausea is crucial. This may involve keeping a food diary to track triggers. The ginger supplements. Ginger has been traditionally used to alleviate nausea, and some studies suggest it may be helpful for HG. However, more research is needed to confirm its effectiveness. For the psychological support, the emotional distress associated with HG can worsen symptoms. Counseling and emotional support can help manage stress and anxiety, potentially improve the overall experience. This slide emphasizes the importance of psychological support and close monitoring managing hyperemesis gravidarum or the HG. Psychological support. This highlights need for counseling and emotional support to address the stress and anxiety often associated with HG. The constant nausea, vomiting, and potential complications can take a significant toll on a person's mental well-being. Providing emotional support can improve coping mechanism and overall well-being. The number 1 is the close monitoring and early intervention. The slide stresses the critical role of close medical monitoring and promote intervention to prevent serious complications. 2 specific complications are mentioned. The first one is Renix encephalopathy. This neurological disorder caused by vitamin B1 deficiency, severe and prolonged vomiting can lead to poor nutrient absorption, including thiamine deficiency. Renix encephalopathy can cause confusion, ataxia or loss of coordination, and ophthalmoplegia or paralysis of eye muscle. Early diagnosis and treatment with the thiamine are vital to prevent permanent neurological damage. The number 2 is the fetal growth restriction. HG can lead to poor maternal nutrition impacting fetal growth and development. Close monitoring of fetal growth is essential to identify and address any growth restriction early.
So our pharmacological therapy is prednisone, generic name is prednisone, and the brand name is Deltazone. Route of administration is oral but can also be administered intravenously in hospital setting if needed. And the dosage for hyperemesis gravidarum, oral dosage, the typically starting dose is 10 to 20 mg per day. This may gradually reduce once symptoms improve. And then the therapeutic class, anti-inflammatory, and then the pharmacological class is glucocorticoid, a type of corticosteroid. So mechanism of action. Prednisone is a synthetic corticosteroid that mimics the effects of cortisol, a natural hormone produced by the adrenal glands. The corticosteroid, like prednisone, exert their effects by binding the glucocorticoid receptors, leading to a variety of actions. Anti-inflammatory effect, prednisone suppresses the activity of inflammatory cells in cytokinesis, which involve the pathogenesis of nausea and vomiting in hyperemesis gravidarum. Indications. Primary indication for prednisone is the context of hyperemesis gravidarum is to manage the severe nausea and vomiting that can be controlled with other antiemetic medications. Indications. Prednisone should not be used in the following situations. Systemic fungal infection, example, the candidiasis or hepatoplasmosis, because corticosteroid can be exacerbate fungal infections. Active tuberculosis, corticosteroids can be worsen infection by suppressing immune responses. Prednisone should be used in caution in individuals with peptic ulcer of history of gastrointestinal bleeding. Steroid may increase the risk, and psychiatric disorder as steroids can affect mood and mental health. Side effects. Common side effects of prednisone can include the gastrointestinal upset, stomach indigestion, peptic ulcer, weight and gain, psychiatric mood swings, anxiety or europia, or even psychosis. Endocrine suppression of hypothalamic pituitary adrenal excess leading to adrenal insufficiency if the drug is suddenly stopped. Infection increase susceptibility to infection due to immunosuppression. Nursing responsibilities. Monitor for side effect of prednisone, including the GL disturbances, mood changes, fluid retention, and signs of infections. Ensure the correct dosage. Administer the prednisone as prescribed either orally intravenously. If using IV, ensure proper dilution and infusion rates. And educate about the infection risk. Encourage the patient to report signs of infection such as fever, sore throat, or unusual tiredness.
So next is the nursing care management. So first, we need to withhold oral intake until vomiting stops, because eating or drinking while still vomiting can worsen dehydration and irritation in the stomach. So no food or fluids until vomiting is controlled. Second, administer IV fluids. So why IVF? Severe vomiting leads to dehydration and loss of essential electrolytes like sodium and potassium. IV fluids replace these. Example of IV is the lactated ringers plus vitamin B6 to prevent dehydration. Then third is to monitor intake and output. This means tracking how much fluid the patient receives and loses. So if urine output is very low or vomiting is excessive, it may indicate severe dehydration. Then fourth, encourage small frequent feeding. This is to prevent nausea from large meal. This helps the stomach adjust gradually, so we start with clear liquids, then move to dry crackers or toast, and eventually soft foods every 2 to 3 hours to prevent nausea from coming back. And then fifth, we administer antiemetics like ondansetron or metoclopramide to control nausea and vomiting. This medication helps the patient tolerate fluids and food better. Then lastly is to provide emotional and psychological support. HG can be frustrating and exhausting, leading to stress or even depression. So we must reassure the mother, explain that HG is not her fault, and encourage her that with proper treatment, she will recover and have a healthy pregnancy.
In summary, hyperemesis gravidarum is a serious condition that requires proper assessment, diagnosis, and management to prevent complications for both the mother and baby. Early intervention is crucial to ensure the well-being of the patient. That concludes our report. Thank you for listening.